Hello, thank you for listening in. Today I've got Dr. Caitlin Dean. Is that right?
That is right. I am now Dr. Caitlin Dean.
Yes, you are.
Yes.
Real doctor, not one of these honorary medical ones. And
Yeah.
you're the chair of Pregnancy Sickness Support Org.uk.
Yeah.
Very important subject. Um, Not in the media that much, I would say. Um,
Not as much as it should be,
I
and in
got
the
it.
right
Now,
way.
now you work with women who are suffering hyperemesis gravidarium. Would you tell us a little bit about yourself and about the work you're doing, just to kick us off?
Yeah, absolutely. I started as a nurse, general nursing. I was working in practice nursing when we decided to start a family, and I had I had vaguely heard about hyperemesis before during my midwifery placement as a student nurse. There was a lady that had been admitted, but I didn't really know much about it, or it never occurred to me that I would suffer it or anything like that. And then I did suffer it with each of my pregnancies, and
All three.
all three. Yeah. I did have a couple of miscarriages where I didn't suffer it,
Oh, sorry.
which is that's all right. It's part and parcel of it. But it's frustrating. That what was most frustrating about those was people telling me, oh, but maybe you're just going to not get it this time. And it's like, nah, that's not the case. Is that the pregnancy is not going to continue. So I suffered it with each of my successful pregnancies, and it decimated my career as a practice nurse, because not only do you need maternity leave, but you're off the 9 months beforehand.
Yeah.
And then I had small children and so on. But before my third pregnancy, my husband said, look, if you really, really want to do this, then we need more support. So at that point, I found pregnancy sickness support, which had already existed, but it was a very small charity, which I hadn't found during my previous pregnancies. You had to search quite specific terms to come across it on the internet and so on. So I got in touch with them in advance and said, look, got information about preemptive treatments and so on. And then I got involved with the charity, and my dream was to set up this kind of peer support network so that people who are suffering with it can be supported by people who have been through it before and understand the challenges of the condition and so on.
Yeah.
So I sort of set that up prior to and during my third pregnancy. And then my career kind of went down that route, and I ended up going into research and so on. And I've just got my PhD in medical research, specifically about hyperemesis. So that's how I got involved, and my sort of professional background. The charity, from when I got involved, actually, what date is it? 14th. So on the 12th of December was when we, 10 years ago, relaunched the website in a format that hopefully people would actually sort of find people who needed it and so on. And since then it has grown phenomenally. So that, I started with that literally a tiny handful of volunteers, maybe 4 or 5 women who could support women who contacted the charity, and we'd get maybe a call a week to a recorded voice message system that we would call back within sort of 48 hours, and the trustees would be on a rota for checking the messages and so on. And now we have an office with 6 members of staff,
Wow.
one that works at home managing purely volunteers. We've got over 550 volunteers.
Wow.
Um,
I mean,
we
this all started in this context barely 6 years ago, right?
10 years ago.
10 years ago.
So
Wow.
yeah, so 10 years ago and 2 days. And yeah, now we take over 3,000 new contacts every year.
Right. Okay. For your organisation to grow in the way that it has.
Sorry, just one
No,
second.
you're okay. You do your thing. But for the listeners, she hasn't got COVID anymore. Honest, and we're
It's not
not.
COVID.
Yeah. So we'll.
The non-COVID cough, and it's actually worse than the COVID cough I
Oh
had
no.
4 weeks ago.
Oh dear. Oh dear. What I was going to say was for the growth of your organisation to be so profound, that points to an unmet need. So what is
Absolutely.
the extent of hyperemesis gravidarium in the UK then?
So you're looking at around 1% of pregnant people will be sort of diagnosed with hyperemesis, which is about sort of 15,000 a year. However, there's a much larger group of people who won't ever get that diagnosis, who have nausea and vomiting of pregnancy that is severe enough to really impact their lives, make them absolutely miserable, challenge their relationships, make work difficult, need time off work, make, you know, looking after other kids really difficult, and so on. And that's more like 30 to 35% of pregnant people will have clinically significant symptoms, which really, with a bit of treatment, probably they could manage and get on with life.
35%?
Yeah, it's really high.
That's an enormous number. Now, so what's the distinction then between vomiting carrying on throughout pregnancy? Because I mean, traditionally, I suppose, sickness, as a midwife way back, I might be out of date, we would say, oh, potentially we would say, God, and it sounds so patronizing from the mouth of a man, let alone another woman, we would have said, well, it's due to high levels of human chorionic gonadotrophin, you know, which is about the viability of the pregnancy. So in one way, it's good. All that sounds very patronizing now.
Yeah, right? Well, it can be reassuring, particularly if you've had a previous loss. You know, to get some sickness can be reassuring, and it is. Regular pregnancy sickness is associated with a reduced risk of miscarriage. That's not to say that if you're sick, you're not going to have a miscarriage. No. But it is associated with a slight increased risk. So, you know, if you've had a previous miscarriage where you weren't sick at all, and this time you are sick, that you can take that as a reasonably positive sign.
Yeah.
The problem is that, you know, we're talking about a spectrum here, and sickness in pregnancy is a normal part of pregnancy. Almost everyone will have at least some moments where they feel nauseous in early pregnancy. And most people will have it enough to really sort of notice it and go, oh, that's morning sickness. Yeah. It's very much a normal part of pregnancy. However, it shouldn't be interfering with your day-to-day life. It shouldn't be, the nausea shouldn't be constant. It shouldn't be so severe that it's like all consuming. Yeah. It shouldn't be stopping you from eating and drinking. So, you know, like as a kind of comparison, you know, when you've got just like a bit of a niggly headache, but you know, you get on with it and you go to work and you drink some water and you just sort of manage it, versus a sort of blinding migraine where you cannot get out of bed and it consumes like you can't think of anything else. Yeah. So that's kind of, you know, a comparison that perhaps more people can understand. But, you know, normal is just waves of nausea, maybe occasionally vomiting.
And would we expect this kind of nausea to have settled by about 12 weeks?
Normal nausea and vomiting in pregnancy, yes, around 12 to 14 weeks. Yeah. When you get into that mid spectrum, like I was saying, that sort of 30 to 35%, where it's actually really quite unpleasant and you might need a couple of days off work, and you know, you might be losing a bit of weight and struggling a bit to eat and drink normally. You're having to sort of manage your symptoms. That is more likely to be more like 16 to 20 odd weeks it can go on for. Right. But then with full-blown hyperemesis, where the nausea is constant, you know, you're not managing to eat and drink, you're losing weight, and you know, it really is taking over your life. Unfortunately, although you may make a good recovery at 24 weeks, it's unusual for it to completely clear up before that, and it also is not unusual for it to go on throughout the entire pregnancy
and need hospitalization.
Yeah.
Was it thiamine? I don't know. But
thiamine is an important one because it doesn't treat the sickness, but you can get, if you're very sick and you're very malnourished, you can get deficient in vitamin B1, and you can get a neurological complication called Wernicke's encephalopathy, which is rare, but it does happen.
Easy for you to say. Say it again.
Wernicke's encephalopathy.
All right.
It's a swelling of the brain. And actually, you know what? women do still die of this,
No.
even in the Western world. People think of it as like, oh, you know, yes, it's horrible, but you'll be fine and the baby will be fine. In reality, like, it's rare in this country and in, you know, the Western world, but there are occasionally still deaths from this, from things like Wernicke's encephalopathy, where it's not been managed and she's been allowed to get so ill that, you know, she can't maintain it. And of course, a lot of babies do die from it because a lot of people can't maintain the pregnancy under those circumstances.
Right. Well, my late wife, we had 5 children under 6.5, and looking back on that experience now, she was sick throughout the whole of all 5 pregnancies, to the point where she lay on the sofa.
Yeah.
And it had, and you imagine, I mean, that the house was it was not an easy place to be in, because, you know, I was coming home from work and suddenly everything, no one will feel sorry for me, I know, but as a young man, 25, 26, with my partner lying on the sofa unwell, she never received a diagnosis of a Hyperemesis Gravidarum. In fact, she went on, sadly, to die and have chemo. And when she was on chemo, I remember thinking, God, this reminds me of when you were pregnant, right?
Yeah.
So I just, there'll be people out there listening to us now, you know, who are wondering, well, how do you, first of all, what do you do if you're in that situation? I mean, my wife, I remember, my late wife, sorry, with the 3rd child, someone suggested ginger capsules and B12 or something, right? Now, we did that, and it was better. She experienced some peripheral neuropathy, which I now know is probably a side effect of the B12, which is transient, right? Yeah. But when I went to do a return to practice, I was thoroughly discouraged from recommending B12 because of the peripheral neuropathy and all the rest of it. So where are we at currently? What kind of
support? And also, I don't think B12 has any impact on
all right, so
B6
right?
maybe, or but even that, I mean, you know, the issue here isn't a lack of B vitamins. It can be that it could become a complication of the condition.
It was probably placebo, I guess. The ginger is historically a hyperemetic, isn't it?
So meant to be an antiemetic. The problem is that women. So we did a survey some years ago of women who had been admitted to hospital for hyperemesis in the previous 5 years, and about their experience of being told to try ginger, and literally everyone has heard of it, and almost everyone had tried it in some way, shape, or form. And no one found it improved symptoms. We're talking about hyperemesis here, not just a bit of regular pregnancy sickness. And over 50% of people said that it caused harm. It made their symptoms worse. It caused acid reflux.
I was going to say
it was painful to vomit back up. It tastes horrible. It repeats on you if you take these capsules. And the impact of a healthcare professional suggesting it to you when you're that ill, it eroded the trust of they had in that healthcare professional. And there were women saying, if this midwife thinks that ginger is going to fix this illness, what else doesn't she know? How can I let this midwife near me when I'm giving birth to my baby? So
that's an important point, Caitlin. So you're actively saying,
don't suggest it.
Don't suggest it.
Don't even suggest it. Just don't suggest it. Like, they've tried every pregnancy magazine, every website, they know about ginger. You can guarantee they know about ginger. And if they want to, they'll have tried it. And the other problem is things like ginger biscuits don't actually have a lot of ginger in. They're ginger flavored. The biscuit might help. The only really evidence-based thing is that eating very small amount, like nibbling constantly, not allowing your stomach to get empty, can genuinely help. Now with full-blown hyperemesis, where everything's coming back up, obviously, you know, and when a healthcare professional suggests that, you need to make sure you're not implying that you think she's eating large meals and throwing them up. So, because I've had that before, where I just thought, do you think I'm like chowing down a roast dinner and then complaining that I'm sick? So, but actually not letting, but it's explaining that what I'm talking about here is really sort of divide a piece of toast into 4 and take half an hour overeating it, so that it's a constant thing. And for that sort of 30% of women that, you know, aren't actually ending up in hospital and are managing to eat something, that can potentially help.
Right.
And then it's also finding what works for you. So not eating at the same time as drinking, sort of alternating them, and just eating whatever you fancy. When your body has broken down food, a calorie is a calorie, regardless of where you've got it from. If that's crisps or chocolate, it's fine. It's a calorie, and that calorie is more important than not having a calorie.
Yeah.
So that's an important thing to remember. In terms of treatments, I mean, so there are plenty of medications out there that are safe and effective. And it's interesting you mentioned about your late wife and the chemotherapy, because I do know people who have had both hyperemesis and chemotherapy, nausea and vomiting. And so far, I've yet to meet one who says that the chemo is worse than the hyperemesis. It's very comparable levels of sickness. But what's interesting is if you have a patient with chemotherapy, nausea and vomiting, the treatment of that is very proactive.
Yeah.
So if they think she's getting dehydrated, they'll stick a drip up.
Yeah.
They'll give her treatment. You know, they're empathetic. They might still suggest some alternative therapies, and ginger and so on. But on the whole, they'll be like, look, you're not able to keep food and fluid down, so let's get a drip up on you.
Yeah.
But with a patient with hyperemesis, once you're pregnant and you're sick, that all goes out the window. And they're really tight with giving you fluids.
Well, and I suppose antiemetics, because I think
antiemetics.
I think my late wife, when on chemo, had ondansetron.
Yeah.
Full on. I mean, a full on antiemetic, right?
Yeah. And we use that in hyperemesis, but there's misnomers around it. There's misinformation about it. There's fear around it. Ondansetron is now one of our most tested drugs in pregnancy for sickness. And, you know, there's more research about that medication than cyclizine, that's been around for 60 years, and ondansetron's been around about 30 years. Now, through extensive research, the only association they've been able to find, which would argue is actually to do with confounders, to do with malnutrition in the population that you're studying, is that there's an increased risk of 3 in 10,000 oral clefts in the babies exposed to ondansetron, as opposed to the babies not exposed to ondansetron. And you're talking about a baseline of globally at about 11 in 10,000. So you've got an 11 in 10,000 chance of having a baby with an oral cleft, right? And then if you take ondansetron, you've got a 13 in 10,000 chance.
Right.
So to me, as someone who needed ondansetron, that's like, well, that's safe.
Well,
I mean, what's the alternative? Like, terminate? And with my second, that was the alternative.
And when we start talking about these kinds of numbers, there seems to be a confounder when we're talking about healthcare, because, you know, I've got, a 1 in 15,000 chance of going in my car today and having a car crash.
Exactly.
1 in 15,000, I think it is, maybe slightly higher than that.
Yeah,
I take that risk. I take that risk every day, right?
Yeah, exactly. So when a doctor says, oh no, you can't have ondansetron in the first trimester, it's not safe, that's what they're referring to. 3 additional babies in 10,000 having an oral cleft, which what they're not telling you is that if you are so unwell that you're malnourished and you're not taking your folic acid, there's a higher chance that your baby will have an oral cleft. So if you take the ondansetron, but it means you can eat, you can take the folic acid.
Of course.
You're actually balancing that out. And that isn't shown in this research because they're not able to account for that confounder in this research.
Yeah.
So to me, it's one of the safest drugs that we've got. I mean, most of the other drugs also, they cannot find any associations.
And we can use it potentially under 7 weeks.
Yeah. Yeah.
Wow.
So there's no reason why not. And actually, it's all the more important too, because what we do know is that malnourished in the first trimester is actually genuinely teratogenic to the fetus. So you're increasing risk of cardiometabolic disorders, of autistic spectrum disorders. There's good research around that showing that malnutrition in the first trimester this old wives' tale that, oh, but the baby's fine, the baby's this tiny little parasite and it takes what it needs from you. That's not true. We know from long-term studies where they looked at the Dutch famine cohort, which is quite similar, where suddenly the population was plunged into malnutrition. Their food supply was sort of cut off for about 4 or 5 months. And then at the end of the Second World War, and then they reopened, or they managed to get food again after that. And they followed that cohort through. And actually, it's the babies who were pregnant in the first trimester that had then increased chance of things like cardiometabolic disorders.
Yeah, and makes
whereas
sense,
the women who were later in pregnancy, it wasn't so. They might have had a lower birth weight, but it wasn't.
And that makes sense, doesn't it? Because for the first 7 weeks, all the systems of the body are
and your genetics that you can. So they're being born thinking that they're being born into a famine situation. And their genetics kind of alter, and therefore, maybe then when they have a regular Western diet in their middle age, they're more likely to get diabetes and so on.
Yeah, makes sense in the context of the evolutionary model.
Exactly, and therefore, when you've got a healthcare professional who's trying to talk to a woman about whether or not to take a medication, at the moment it's really one-sided. They say things like, well, we don't know that it's safe. We can never really know that the medication is safe. We don't really know what the harms are. And, or they'll say, well, there's an additional 3 in 10,000 oral cleft with on downstream. But what they're not saying is, but we do know that being malnourished and dehydrated in the first trimester is not okay.
No, yeah.
So, and they don't help you to weigh that up, and that's really unfair. And
the folic acid trial had to be stopped for ethical reasons.
Yeah,
because not giving it's not.
And yet they tell a woman with hyperemesis that it's fine to be starving and to not take your folic acid and so on. So you're making these decisions based on snippets of information and not the whole picture. And I think that's a real problem in our world at the moment.
Well, but potentially, agreed, and potentially legal ramifications for the health services, given the nature of informed choice and women being given as much of the information as is possible.
Exactly. And especially when you get into the realms of women who sadly end up choosing to terminate an otherwise wanted pregnancy because of hyperemesis, who hasn't been offered all the medications and has, in some cases, been denied those medications. I mean, personally, I think there does need to be some legal ramifications to that kind of thing.
For accountability.
Yeah, exactly. But unfortunately, that is where we're at with it. And we've got, a mountain still to climb in terms of that information. I think a pregnant woman who's dehydrated, the threshold for giving her IV fluids should be lower than anyone else. Let's
I mean, but then you would, I guess, get some pushback from certain parts of the birthing community saying, well, hold on, we don't want to treat women automatically like birth is a pathology.
But hyperemesis is not a normal part of pregnancy, and it's not, I think, yes, we're not talking about giving drips for regular morning sickness. And quite honestly, what regular busy mum who's pregnant again or whatever has got time to go and get a drip if she doesn't actually need one?
No, good. And I remember, I remember my last biological son. I've got 2 stepchildren and an adopted son. Joe was, we used to joke with him that he was the product of a burst condom. We were very open. He wasn't planned. In fact, he now thinks he's indestructible because he had meningitis at 18 months, bacterial meningitis, and survived. So he thinks he's indestructible now. And I say, actually, Joe, we haven't got a birth certificate for you. We've got an apology note from Durex. but that's kind of a family joke. But when my late wife fell pregnant with Joe, I remember her weeping on the top of the stairs.
Yeah.
Because she had 4 other children. I'm getting emotional now. And she had no sense of how she was going to manage.
Yeah.
And it was just a desperate feeling of being lost. Yeah. And for her, at the time, termination wasn't something she would consider.
Yeah.
And I remember how anguished we felt, and that kind of moves me really, because it sounds
Yeah,
to me like there's a lot of people out there um, who have no idea that this kind of support is available to them,
yeah.
and are being told by well-meaning midwives, because I'm embarrassed to say I've said some of those things,
Mm. Before
that
suffering myself, I would have done.
yeah. So what can we do? I mean, what? I
Yeah,
mean,
and I'm very honest with my kids as well. They know the reason I work my butt off for a charity and not getting paid for it and all the rest of it, and my PhD and everything else, that they've sacrificed, you know, mum's in the office for the weekend, like
yeah,
for the last 4 years kind of thing. They
yeah,
know that I do this because I reached the point with that, with the first two certainly, of seriously considering terminating them,
yeah,
and that I don't want other people to terminate the babies that they've wanted and tried for.
yeah.
If they, you know, want the baby, I mean, don't get me wrong, I'm pro-choice, but,
Well,
you know,
yeah, whatever.
if they want the baby, like, I don't want them to. The problem for our population, for the hyperemesis women, is that these are unwanted terminations,
Yeah,
unwanted babies tried for. We've had women who've conceived through IVF who have gone on to terminate, come through our charity. So that's why, yeah. So we're quite honest with our children about that,
yeah.
for that reason, really. So what can we do about it? I mean, you know, and frustratingly
Well,
for
hold on
your wife.
before you go on to that, because I think we should spell some things out very clearly, so that this interview then becomes a resource for other birth professionals who want to support suffering women and
Yeah,
families. Let's put to sleep then C-bands.
yeah. I my
Bollocks, yeah?
youngest is 9. I have stars on my wrist because I wore them for 9 months, 3 times. In the first pregnancy, I kind of hoped they did something.
Yeah.
After that, it was so that I could say, yes, I've tried them, because the implication is if you're not wearing them, you're not trying hard enough to help yourself.
Yeah. It's your own
And that
fault.
shouldn't, that's not on. That's, you know,
No.
I mean, I don't know whether they work or not, but they're
Who
certainly
knows?
not,
Or,
yeah,
so
not pure.
let's talk about other stuff then. What about acupuncture?
Yeah, I mean, with all of the alternatives, I mean, acupuncture is quite, if you can afford it, fine. It's not, you know, it's a fairly expensive thing. For women with hyperemesis, it's going to generally involve
Daily.
getting dressed, getting into a car, getting to an appointment, affording to pay for it when you're probably on sick pay.
No.
Yeah, it's not a very, very accessible thing, even if they can come to your house. I mean, it's not a cure. If it worked, it would be wonderful.
I wanted to cover it. I wanted to cover it anyway.
Yeah.
So let's just put all that.
It's unlikely to do harm.
Yeah, exactly. Well, that's a nice way of putting it. So let's put all the alternative stuff just to one side for a moment.
Yeah.
Now let's talk about degrees. You've already been very clear that nausea in pregnancy is normal. There's a higher level. There's human chorionic gonadotrophin, which is interacting.
Yeah, although that's probably not the actual cause, but this is probably not the time to get into the.
No, let's not do that.
New discoveries about genetics.
Yeah,
so
I've just displayed my ignorance, and you can be sure that will be edited out.
Okay. There's a whole new. It's only in the last couple of years, and it's very exciting. But this isn't the format to start trying to explain it. And
let's not worry.
I'm not a genetic scientist.
And I probably won't edit this out because that's quite funny. But anyway, so there's a level of nausea that can be expected in early pregnancy up to about 12 weeks. Fair to say?
Yeah, absolutely.
And most women will just
eat little and often.
Yeah.
Rest a bit when they need to.
Yeah.
You know, rework their day schedule so they go out when they're not feeling sick.
We're not talking about those women. They need support from their.
They generally don't need support. They're not traumatized, with the exception, if this is for healthcare professionals, I would like to point out there's a couple of exceptions to that.
Go.
If you've got a woman who already has a metaphobia, I do know a woman who actually would love to have kids but won't go through pregnancy because she is so terrified of sickness. Now, if she could be reassured that she would get medication even for the slightest bit of nausea, maybe she'd get her baby.
Oh, that's interesting.
So there is that. So previous psychological issues would be something. And we've also had women who have had sort of psychological damage from previous domestic violence involving vomit and stuff. So just be aware that some women may have specific problems with vomit and nausea. Brilliant. That even a tiny amount of nausea can cause problems. But that's the exception. That's for healthcare professionals.
And that's a fantastic distinction, given that omdanzitron is potentially a solution.
It's safe, yeah. I mean, just give
Yeah,
it.
yeah, I love that. Yeah. So we're not talking about those women, the ones
No.
that we mentioned. So for this 35% of women, right? First of all, how do they know they're in that category? Is that a silly question?
Yeah, no, it's not, because it's something we get our helpline asked all the time.
Right.
And the fact that you're asking the question means you're probably in that category, because quite honestly, everyone expects nausea in pregnancy. You know, like we all know it, right? Like that's the symptom of pregnancy.
Yeah.
We expect it. And actually a lot of women, especially if it's a tried for wanted baby, it's actually often in the first pregnancy a welcome sign. It's a rite of passage, isn't it? To experience more. If you plan to get pregnant and you want to be pregnant, you kind of want the whole experience, and that includes a bit of morning sickness early on. I think I certainly thought that, like, it was, you know, I was like, oh, this is morning sickness.
I couldn't comment, of course, being the male of the species, but go on.
But, you know, my husband, the first morning I was sick, was like, oh, morning sickness, oh, how funny.
Yeah.
You know, and then of course,
all right for him.
Yeah. Yeah, exactly.
Yeah.
So if you're thinking, my God, this is much worse than I was expecting, and you know, I'm really struggling here. I'm really not managing to eat very much. God, you know, then you're getting into that realm of like, that's not normal, and you shouldn't have to put up with it. And we do have treatments. We've got a licensed medication in this country. It's not easily accessible everywhere because not all CCGs have it on their formularies. Scotland and Wales have been a bit difficult about it, but it's called Zonvia, and it's a licensed medication for nausea and vomiting in pregnancy. It's been around 40 plus years in other countries. It's, you know, so some doctors here are like, oh, it's new. It's not new. It's been around for decades. It's just been licensed here now.
How much?
How
much is it?
It's quite expensive.
Yeah.
So you can get it privately, and that's one of the issues. I think that's why, you know, it's expensive, but not compared to, say, going through a round of IVF.
Yeah.
So you're talking about, I think 10 days worth is maybe 30 quid.
And this drug you're talking about is kind of, you're saying it's more effective than ondansetron?
No, it's not. But it's first line.
Right.
So the research around its safety, the fact it's licensed, means that it would be the first thing you try. It also does, you take it at night, and then it's a slow release. So by the time you wake up in the morning, your blood levels are quite stable with it. Yeah. So it's a first line, and for that group of women who, you know, actually sickness is making it difficult to get up and go to work, then that medication can help. And again, you've got thresholds there. So if you've got a woman who actually, you know, financially is fine and has childcare for the kids, and doesn't work or whatever, she might be willing to put up with a much higher level of sickness compared to a single mum who's going to lose her house if she doesn't get her ass to work next week.
We've got to, we really have to treat people as individuals, you know.
Yeah, absolutely, we do. And people have got different thresholds for what they're able to put up with and tolerate. You know, if you've got a very supportive partner, you might be able to tolerate higher levels of sickness without medication than someone whose partner's a nightmare down the pub and puts in financial difficulty and so on. And they're going to need more aggressive medication earlier on. So that would be first line, but it's very similar to cyclizine, which is much cheaper, and most doctors are willing to prescribe. Cyclizine is pretty much the same drug that's in Zonvia, except for that it's the same kind of class, but it's not the slow release, and it doesn't have a B vitamin in with it. But cyclizine is pretty much the same sort of thing. So that can, for that moderate group, taking some cyclizine can make it so that they don't end up in hospital, and that they can get back to work, and they can look after their kids, and they might still not feel great.
But their first port of call should be GP.
It should, yes, and we do have some wonderful GPs in this country, but we also have some not great GPs. Thank you. Someone's just brought me a cup of tea.
Oh, very nice. I haven't had one yet.
So they should be our first port of call. Unfortunately, you can be met at your GP with resistance, with being told that this is normal part of pregnancy, that there's nothing you can take. And if that's the case, you need to find another GP and persist,
Yeah.
and could say things like, you know, I was expecting sickness, but this really isn't normal actually, and then call our helpline. Pregnancy Sickness Support website has our helpline, and we can help to find you a better way of getting treatment.
Can you buy a private prescription online?
I don't think for Zonvia you can.
Okay.
But I'm not entirely sure on that. There are private online doctors, but you see a lot of them won't do pregnancy, which is a shame.
Because of indemnity.
Presumably, so that's a bit frustrating. I mean, in a lot of Europe, you can buy their equivalent of Zonvia over the counter.
Yeah.
Hopefully, one day we'll be able to buy Zonvia over the counter.
And antibiotics. Funny enough, yeah. You know, I've been in Spain and felt, you know, I had an infection.
Yeah.
So you've covered the woman that is asking the question, therefore is probably in this category. We're going to do all your website details in a minute, and they'll all be in the show notes. So at what point are we expecting the healthcare professionals that are supporting this woman to identify those that need more medical intervention? Because I'm guessing quite a number fall through on the cracks on the basis that the healthcare professionals are quite stretched, so they'll be seeing their midwife less often. You know,
that is the case, and obviously COVID did have really unpleasant ramifications for that sort of thing. People being told, I've got real patients to deal with, you're just pregnant, get on with it, kind of stuff. So hopefully we're sort of moving beyond that again now, but you just contact us and we can help. Where you're getting to the realms of hyperemesis is, so with a first pregnancy, unfortunately, some people, because they think it's normal and they're being told it's normal, they'll reach the point where actually giving them a prescription of cyclizine to go home with is a bit late, and they're already so dehydrated and unwell that they need to go to hospital. But for a lot of women, especially if you've got a good GP who you go to early on, kind of that, is it hyperemesis or isn't it? Almost is that point. Does the cyclizine work? If it does, great. You've got nausea and vomiting of pregnancy, worse than average, but you know, get on with it, get on with life, start eating and drinking again, take your medication, and hopefully you'll recover in the second trimester. If you go home, you take cyclizine, 2 days later, there's absolutely no improvement, or you're getting worse or whatever, then it's hyperemesis. You know, and at that point, you still don't necessarily need to go to hospital if you can manage your fluids at home and so on. But you certainly can step up to other medications, and it would be adding in other medications because they work differently. So there's other ones like metoclopramide, metoclopramide, domperidone, and then ondansetron. And even beyond ondansetron, there is steroids that we can use as well. And then very occasionally you get cases that are unresponsive to all the medications, and they're going to spend most of the pregnancy in hospital, and very occasionally they have to terminate to save the mother's life. But that is incredibly rare. And very, very unfortunate and distressing when that happens. But some women, even with proper hyperemesis, it's important to remember that even with the medications, they're not curative. They are palliative, and it is a case of managing it. So they may, and with cyclizine, for example, if you started that at say 6 or 7 weeks, bear in mind that the condition is getting worse until about 9 to 11 weeks. So you could start it at 7 weeks and you think, oh yeah, this cyclizine is working. And then by 8-9 weeks, it seems like you're getting worse. And what we find is that women go, oh, it wasn't working, so I stopped taking it. No, it probably was working, but your condition's getting worse because of the natural progression of the condition. So it's important to keep taking it and add in other treatments along the way.
Got it. And we know more about the arteriology now, do we? In terms of the progress of the condition? Yes,
we do. We still need more research. There's very little in the actual evidence, even about, I mean, you know, we still have debates with doctors and midwives who don't believe that if you're still ill in the second and third trimester, that it could be hyperemesis.
And I hate to say it, being a man, you know, this only affects women, right?
Well, it does, yes. I mean, I must say, I don't know what your stance on your podcast is or whatever, but it does affect birthing people. So we have supported people who identify as men.
I understand.
Yeah,
Yeah,
so
I
we have
understand.
we have supported people that
Yeah,
identify as men. So
thank you for that clarification.
it only affects uterus owners.
Yeah,
Yeah, but either way, like you have to be
yeah.
capable of getting pregnant to suffer
Yeah, I
hyperemesis.
got it. And in the context of, I suppose I was talking in the context of historical evolving women's rights.
Yeah.
And I'll speak in those terms
Yeah.
in that context. You know, we know that, for example, the highest cause of death for a birthing woman at a year is suicide post
Yeah.
mental health issues, according to the confidential inquiry into paternal deaths.
Yeah.
And if those kind of figures maybe were available affecting men, we might have seen more work being done. That's all I'm trying to say.
Absolutely. And that leads me into a new thing that we haven't talked about yet, and that is the mental health impact of hyperemesis, because it doesn't take many weeks of being that ill to start really becoming very, very depressed, and a bit being traumatized from it. We talked briefly beforehand about trauma and so on, and actually what a lot of our women, the sickness itself can be very traumatic, and all the smells and the physical experience of being sick. But what also is traumatic is being so ill and being told by people that it's normal and that you should be happy and grateful that you're pregnant. And so, and that can be so traumatic, to be dismissed and devalued and not believed that you're so ill. That can be incredibly traumatic. And it's very lonely. It's incredibly lonely being at home sick for so long, when you should be happy and attending birthing classes and so on. And that confidential inquiry and the high rate of suicide, what's really important to note is that social isolation is the leading risk factor for suicide for that population. Now, for our women with hyperemesis, that social isolation is not starting at the point where they take their maternity leave from work, have their baby, and suddenly are at home all day and feel like their friendship groups have changed and blah, blah, blah. This is starting from the start of their pregnancy, where they've got friends who are saying, well, you should be grateful. I can't, and like telling them to try ginger, and out of sight, out of mind, they're getting on with their work and they just forget about you for weeks and months on end. And then, of course, you have your baby and you think, okay, great, I feel well now. I'm going to go to this mother and baby group. And, the mums sit around and they talk about their pregnancy and their birth experience. And someone says, oh, yeah, I was sick. It was pretty horrible, blah, blah, blah. And you try and sort of share your experience and say, oh, well, actually, I had hyperemesis. I was really, really, oh yeah, I had that, but I couldn't take time off work. I just had to get on with it.
Yeah.
And things like that. And so you go, actually, I'm going to drop out of this group because I don't have a shared experience with these women. I don't connect with these women. They don't understand what I went through. And so, that then you have greater isolation. Sadly we have had suicides in our population.
Yeah, I'm sure. And if someone did a deep dive into that, the group of people that were committing suicide, the old language is awful. That group of people that are ending their lives, we might find a higher proportion of people that have suffered from hyperemesis.
Exactly. And and equally then, even when you look during, we're tackling post prenatal depression and so on more widely in society these days, and there's a bit more of a focus on it, thank goodness. But again, our hyperemesis women are really not represented fully in that group.
No.
And we talked about the damage about malnutrition and so on, but actually depression in pregnancy is also being recognized as having lifelong impacts on the fetus.
Absolutely.
And yet again, our women, it's like, we just need to cheer up. Like, you should be grateful that you're sick. It's a good sign. So I remember in my second pregnancy explaining to begging my GP for treatment, and saying about how, I was also worried. I'd read some magazine article about the effects of depression during pregnancy on my growing baby. And I was there with my toddler, and he said, oh God, you don't want to be worrying. You want to be worrying about the depression you're in at the moment affecting this one. There's more research saying if you're miserable now, your 2-year-old's going to be damaged growing up. And I'm sitting there thinking, so help me.
That is horrendous, isn't it?
Isn't it? It's like, oh, you're damaging both your kids. So I just, yeah, and I mean, yeah, that's
I had a client who didn't feel that her birth was traumatic until debrief. And then when she went to debrief, the reason in the notes for the forceps birth was lack of maternal effort. You didn't try hard enough.
wow.
In that moment, you know, and we're talking about language generally, but in this context, you know, you're making so many powerful points about how
failure to progress.
Yeah, it's just, yeah.
Incompetent cervix. You know, it's
loads of stuff. Now, I just want to cover one thing that just comes to mind. We've been going nearly an hour, and this is great information, by the way. And yeah, women that are experiencing a twin pregnancy. Now, historically, I would have said we can expect potentially a higher level of early sickness.
Yeah,
that's not a myth, right?
It's not a myth. That it's unusual to have a twin pregnancy without any sickness because you've got a lot more of everything going on.
Yeah.
It isn't actually particularly well associated with full-blown hyperemesis, which is kind of a distinct genetic condition in itself. But certainly that 30%, yeah. I mean, if you're carrying twins, it's unusual to not get quite sick, really.
Okay.
But if you were sick with twins, it wouldn't necessarily be the same reason as if you then had a single pregnancy.
Yeah.
You might not get hyperemesis kind of thing. It's kind of in that boundary region. Whereas it's important to know that recurrence is very high with full-blown hyperemesis because it's not a normal part of pregnancy. It's a sort of a distinct illness, really, and it is genetic. And so if you've had it once, what you mustn't do is just go, oh, I'll just wing it next time.
Yeah.
Prepare, plan, contact the charity, get a pre-pregnancy care plan, set your life up so that you can manage, and don't just wing it, because it just doesn't work. You've got to assume you're going to get it. Very occasionally you'll get a pregnancy that doesn't then have it again. It is possible. Prepare for the worst, hope for the best.
So no room for wishful thinking.
No, there really isn't. And if you put all these plans in place and you don't need it, and you've got food full of freezer for your toddler, brilliant. You're just going to have an easier pregnancy.
Brilliant. Now, before we say goodbye, and I'd love to talk to you again, maybe in the new year. I really would.
About it.
Well, I want to talk to you more about your research and why you did it in Amsterdam and all that kind of stuff. I mean, I find that's fascinating, and there'll be people out there that are, you know, just as geeky as I am, and interested in all of that.
Yeah.
But before you go, would you give out all the details of the charity in terms of where people who feel they're suffering can get in contact?
Yeah.
And I've got the website up here.
I was going to say, I'm going to get the website so I can read the phone numbers. I don't know it by heart.
Yeah, well, I've got it, but I think it'd be better if you read it.
Yeah, so it's pregnancysicknesssupport.org.uk is our charity website, and we have a helpline and a peer support network so people can be supported through their pregnancy. We have loads of resources, things you can take to your doctors, to your employers, and so on. The helpline number is 024 7638 2020.
Brilliant.
It's Monday to Friday, 9 till about 4:30, because we need time at the end to follow everyone up. And you know, not bank holidays and so on. Although I think we do have some Saturdays open now. But if you leave a message, we get back to you as quickly as possible within sort of next working day kind of thing.
Okay, and if there's people out there, birth professionals, obviously there's lots of great information on your site for birth professionals as well as for the lay people.
There is.
What if people want to give their time to you? Just get in touch.
So if you've suffered with it, you can act as a peer supporter. Anyone can obviously fundraise for us, raise awareness. Healthcare professionals can do our training that we provide. We do a 3-hour training session. And after that, you can be HG friendly. And also, we don't expect healthcare professionals to really be experts in this condition, because each healthcare professional is never going to see huge amounts of this. So if you get something that's not that straightforward, or a little bit different, or a bit more complex, and particularly things like if they've got a gastric band or anything like that, please get in touch with us, because we are the experts and we can support you to support your patients. We do also, I meant to say, we have a web chat function, and you can WhatsApp us and follow us through social media. But yeah, healthcare professionals can do our training, and if they want to then go on and do more training for their colleagues, we can help with that. If you're interested in research and so on, we can support that as well.
Brilliant. And all the links will be in the show notes, because I'll definitely get them from Caitlin. Are you still writing Spewing Mummy blog?
I'm not. No, I'm not. I've never taken it down because it's just a resource to be there for people. But I thought my PhD kind of took over.
Yeah, but you have that.
I only finished that in October, and I must admit I'm a little bit twiddling my thumbs now. So I'm not quite sure.
What do you do after a PhD, for goodness sake?
Well, I also have a property development company, so that's what the office I'm in at the moment. So I'm not totally idle. I am still running a business with 4 development sites, but it's still not quite enough for me. So I am currently sort of thinking, I was thinking about, we've got a farm as well. I was thinking about getting some inland ewes to have some lambs in the spring. I like to be busy.
We've got an activity addict here.
Yeah.
Hey, thanks, Caitlin, for taking the time, and
thank you for raising awareness about this condition.
Well, thoroughly informative, and thanks for being on.
You're welcome.
Yeah, and thank you for listening. We're done now. Bye.
Bye.